All right, pediatrics, just get a fresh piece of paper. And I'm going to tell you a story. A story about a little baby. Story about a little baby. A story about a little baby. Starts with labor. So I'm going to start from labor. Labor has 3 stages, 4 phases. Stage 1, first part, begins when contractions become consistent. That means occurring at least every 3 to 5 minutes. So first stage of labor, first part. Contractions become consistent and ends when cervix is 3 centimeters dilated. Begins when contractions become consistent, that means at least every 3 to 5 minutes, and ends with 3 centimeters cervical dilation. Fetal position. The fetus is still above the pelvis. So that way I have a picture in my head. Second part of stage 1. Yes, sir. Oh, cervical dilation up to 3 centimeters. All right, second part. Fetal position. They'll ask you where the fetus is positioned. Above the pelvic inlet. That means it's still up here in the belly. Okay? Second half of that stage 1 starts with more than 3 centimeters cervical dilation and ends with full cervical dilation at 10 centimeters. Second part starts with more than 3 centimeters cervical dilation and ends with full cervical dilation, which is 10 centimeters. Now, a brand new mother, primip as we call her, should dilate at least 1 centimeter per hour, whereas somebody who has had multiple babies should dilate at least 1.2 centimeters per hour. Now, the Boers 2s and 3s are the only ones who need to write that number down. Boers 1s don't need to know all that. But because that's going to help you when we talk about, protracted, arrest, and all that stuff. Okay? All right. Second stage of labor begins after full cervical dilation and ends when you deliver the baby. Second stage of labor begins when the cervix is fully dilated and ends when you deliver the baby. No. First stage had 2 parts. Up to 3 centimeters was the first part. From 3 to 10 was the second part of it. That's all still first stage. Okay? All that is just, it's termed latent phase. Latent phase, which means the baby's still up in the uterus, way up high in the pelvis. He hasn't even gotten into the pelvis yet. All right. Now, the second stage of labor, active phase of labor, from 10 centimeters cervical dilation and ends when you deliver the baby. And the baby, on his way out, has to go through 5 Olympic-style maneuvers. He watches the Olympics from in there. All right. The majority of women have what they call anteverted uteri. That means if the woman is facing over this way, her uterus is tilted along her belly like that. That's what anteverted means. Everybody follow me? So if the baby's way up here, look what he's got to do. Descent, so the 5 steps, 5 maneuvers. Descension, so descend first. Then see that he's got to flex his head because he's got to go backwards like that. So descent, flexion. Then since he's inside, internal rotation. Okay? Internally rotate, and then he's going to come into the vagina. So as he comes to the vagina, he's got to extend his head. So descent, flexion, internal rotation, extension as you come to the vagina, and then external rotation. So he rotates one more time when he comes out. So external rotation. 5 maneuvers you must do. Descent, flexion, internal rotation, extension of the head, and then external rotation. And the baby usually presents with what we call LOA, left occiput anterior, which means he shows you the left side of the back of his head. That's the most common presentation over 70% of the time. That's what you're going to see. Now, for the Boers 1s, it helps you to understand that the left shoulder, therefore, is presenting first. That way, if they ask you which clavicle is most likely fractured, which brachial plexus is most likely fractured, see, that's how you use that information. The Boers 2s will use it for more information than that. Okay? That's why they're integrated all the boards now. You see all these questions on boards 1. Cammie. Left occiput anterior. So when they do the external rotation, most of the time you see the left side of the back of their head presenting first, which tells you left shoulder pops out first. Okay? All right, so that's the second stage of labor. Third stage of labor starts when after the baby's been delivered and ends when the placenta is delivered. Here becomes a biochemistry question on boards 1. Which prostaglandin is responsible for separating that placenta? James. Which means you got to know which prostaglandin causes vasoconstriction. PJ. What? I want to know which prostaglandin. Sandeep. PGF is responsible for separating the placenta. Okay? All right. Some books will put in a 4th stage, which is mom's recovery. You know, puerperal stage, mom's recovery. But they'll ask you money about the first 3 stages. Let's go. Yeah, descent, flexion, internal rotation, extension, and then external rotation. Okay? Everybody with me? Now, let me tell you a story about a child coming down from the uterus. Let's go back over the uterus. On the way down, as the baby comes down out of the uterus, guess what? The uterus is contracting around his head, can't breathe. The uterus contracting around his umbilicus, can't breathe. That means if he cannot breathe, he's hypoxic on the way out. Does everybody agree so far? If you're hypoxic, Tina, that causes secretion of what hormone? Erythropoietin. And erythropoietin, therefore, will cause erythropoiesis. At this point in time, Tim, what areas of that fetus's body can produce RBCs? Long bones. Any place else? The spleen. Any place else? Flat bones. Any place else? Liver. So liver, spleen, flat bones, and long bones. We just got to coach it out of them. Just say every site is open. That's why the baby can double his hematocrit in just a few hours of labor. What do we call that? Polycythemia of the newborn. That means that they actually explain it, now you know the physiology. Polycythemia of the newborn is just a baby on his way out becomes hypoxic with every contraction. Is hypoxia stressful, Frank? Yes, it is. What's the first discharge out of the brain whenever the brain feels stressed, Frank? Sympathetic or parasympathetic, Frank? Parasympathetic. What effect would that have on your heart rate, Frank? Decrease it. That's why we talk about decelerations, folks. See what I mean? Physiology applied everywhere. But if you don't know what it is, it sounds like OB to you. See, why are they always talking about variable deceleration, early deceleration, late deceleration? Have you ever seen that it's always deceleration? Folks, it's physiology. It's just one stress or another to that fetus is what you are seeing. Okay, so polycythemia in the newborn. So once you get the baby out, it says, oh, I got too many RBCs out here. They have like a hemoglobin of like 18, 19, 20. That's twice what they need. Then all of a sudden, an organ says, well, you got too many RBCs, I got to destroy a bunch of them. So B, what organ will destroy RBCs for you? Spleen is that intravascular, extravascular hemolysis. Extravascular hemolysis, and that's what causes the splenomegaly you see in newborn. So if I'm destroying RBCs extravascularly, Maria, what's going to happen to your bilirubin level? It's going to increase. It's going to be mostly direct or indirect bilirubin? Indirect. And that's why we call it physiologic jaundice. So physiologic jaundice is just indirect bilirubinemia caused by the polycythemia in the newborn. The splenomegaly is because the spleen has to remove a ton of it all of a sudden. And now you got all this bilirubin being sent to the liver. Everybody follow me? So that means physiologic jaundice is overproduction of bilirubin. Does everybody understand that? Okay? But when you send it to the liver, Al, the liver is not even mature until 2 months of age. So the other half of the problem, so it's 90% overproduction, the other 10% under metabolism. Because they'll ask you to explain physiologic jaundice. It's overproduction of bilirubin caused by RBCs you have to digest because you don't need so many of them. And then the liver is just not ready for all this bilirubin, so it can't conjugate it all. Michelle, what enzyme in the liver is supposed to conjugate all that bilirubin for you? Tamir, what enzyme? Glucuronal transferase. Its peak activity starts at 2 months of age. That's why this early, physiologic jaundice usually starts about day 3. The liver's just not ready. Does everybody understand physiologic jaundice? The problem, Diana, is if you have too much unconjugated bilirubin, is it mostly fat or water soluble? It will be fat soluble. That's why it gets deposited underneath your skin, in the skin fat. That's why you're yellow. It gets deposited into your conjunctiva. That's fat. That's why your eyes turn yellow. And then it gets deposited into your brain, since your brain is mostly fat. So, what are we worried about? Kernicterus. Kernicterus is when too much bilirubin is deposited into what organ in the brain, Bartholin? The basal ganglia. Remember, chorea-athertotic cerebral palsy. So, the rule is, this has only been seen with ABO incompatibility, but bilirubin is bilirubin. It shouldn't make a difference. So the recommendation for handling bilirubin, if the bilirubin levels go above 25, Chris, what do? Now, above 25, May, what do? What? Exchange transfusion. When the bilirubin goes above 25, exchange transfusion. What that means is you got a syringe with a two-way stopcock, so you got a tube going in this way and a tube going in that way. So on one side you suck out blood, it's got plenty of bilirubin. The other side you squeeze in normal saline. So you dilute everything until you get the levels down. Sweet. All right. So otherwise, if the bilirubin goes above 20 for a term baby or above 15 for a preterm baby, we start phototherapy. If the bilirubin goes above 20 for a term baby or above 15 for a preterm baby, start phototherapy. What the heck is phototherapy all about? Miguel is asking himself. Well, phototherapy uses a wavelength of 270 nanometers. Well, Miguel, that 270 nanometers, that wavelength causes a reaction with bilirubin and turns into a water-soluble compound. If you want to turn it into a water-soluble compound, Jessica, do you want to reduce it or oxidize it? I don't know. Would you want to oxidize it, Jessica? Thank you very much. Then you want to oxidize it. Remember, don't ask it back as a question. Oxidize it. Remember, put oxygen on it. That means it drags more water now. Okay? So the 270 nanometers will oxidize it so that now it pulls water. If it pulls water, the brain has to push it out. Remember, water and fat will never mix. So your skin then pushes it away. Wherever it's been deposited, pushes it out. Okay? Everybody follow? That's how phototherapy works. The problem, however, Nita, is that same wavelength, Monica. That same wavelength is almost equivalent to that of an eclipse. Hey, Monica, when there's an eclipse out there, what did I always tell you? They say, should you look at the sun or not look at the sun? You know how they say don't look at the sun? Why? What would happen to you if you look right at the sun at that time? You would go blind. Same wavelength, folks. That's why we put a patch over the eye of the baby before you turn that light on. Because if the baby looks right at the light, he's blind now. It works for the oxidation of the bilirubin, but hey, it can also burn your retina, and that's it. We're done with vision. So that's why you put the patch over the eye before you turn on the lights. Of course, these days, they now have bilirubin blankets. See, that way there's no light to look at. You just put the baby on the blanket. So the light is coming from underneath them. Everybody understand that? It's the same thing. It's just this way he doesn't have to look at it. Because, you know, babies look straight up to the ceiling. All right? But that's what phototherapy was based on. Use a certain wavelength to oxidizes the bilirubin, but watch out for the retina. All right. So what you do is just start phototherapy, and you just follow the bilirubin levels back down to normal. Everybody understand me so far? So that's a physiologic jaundice. Now, while you got physiologic jaundice, it's important that you worry about breast milk jaundice. Because most moms who are breastfeeding will ask you about this. I heard that breastfeeding will make his jaundice worse. You say, yes, Mom, you are totally correct. However, making it worse is so mild, we don't worry about it. So the point is, you continue breastfeeding. That's the question they're going to ask you. What would be your advice to the mother? Continue breastfeeding. The benefits far outweigh the mild jaundice you're going to get. Okay, that'll be on boards 2. However, on boards 1, they'll ask you the mechanism of this jaundice. How does breast milk suddenly cause more jaundice? Here's the mechanism. Breast milk transmits estrogen. And estrogen is more protein bound than bilirubin. Which means, Tatiana, whoever's more protein bound will displace the other one. Which means here comes estrogen, will push bilirubin right off of the albumin. That means now you got more bilirubin floating around to attach to fat. So it's the estrogen that's prolonging the bilirubin. Okay? The second benefit of continued breastfeeding is you learn in GI. If you want to conjugate bilirubin, you got to conjugate it to what, Tara? The glucuronidase transfer is going to conjugate what to your bilirubin? All right, now. Yeah, that's for bile acids. Linda. Andre. Basil. Malika. What? Glucose. You guys forgot how the enzymes are named? It says glucuronidase. I could swear I hear glucose in there. I told you when you look at it as a detail, you swear you don't even see the clue anymore. It's glucuronidase. It's glucose. That glucuronide is just a modified glucose molecule. That's it. So that's why we say keep breastfeeding. The baby needs the sugar to get rid of this doggone bilirubin. So we found that if you did not keep the feedings going, the jaundice would keep going. All right, so if it keeps going in both instances, why stop the breastfeeding then? Because the benefits of breastfeeding is more than starving that child. So with breast milk jaundice, continue breastfeeding. Mechanism, estrogen displacing bilirubin. So it's not a big deal. Continue. Everybody understand breast milk jaundice? All right, so now I got my jaundice child, and I've treated him. However, there are 3 instances, 3 indications that let you know it's not just breast milk. It's not just physiologic anymore. When do I suspect it's not physiologic anymore? Number 1, if the bilirubin is high on the first day, that is not physiologic. Your body just recognizes there's too much RBC mass. It takes a couple of days to start digesting them, so there's no way you can say physiologic occurs on day 1. Okay? Number 2, if the bilirubin is mostly conjugated. If the bilirubin is mostly conjugated, Diana, well, we just said that the liver is immature, so if it's mostly conjugated, it should have been excreted. That means there's a problem in the biliary tract. That's not physiologic. Physiologic, as Maria said, is unconjugated or indirect bilirubinemia. All right? Third criteria, if the bilirubin rises by 5 milligrams or more in a 24-hour period, that's not physiologic either. So number 1, high bilirubin on the first day. Number 2, bilirubin is mostly conjugated. That means it's after the liver. Or number 3, bilirubin is rising too fast. More than 5 milligrams in a 24-hour period, it is not physiologic. Number 1 cause of bilirubin outside of physiologic, sepsis. Because sepsis puts the baby in shock, and guess what? Now he doesn't have enough blood supply to his liver. That means he's not delivering the bilirubin to his liver. Does that make sense to everybody? If you don't deliver the liver, how's he supposed to get rid of it? Okay? So sepsis is the number 1 cause that you must rule out. That means you got to know how to do a septic workup. Now watch how you figure out a septic workup. If you say a septic workup, that means you're trying to figure out if there's bacteria located where, Cammy? In the blood. Everybody follow? Everybody understand what she just said? You're trying to see, when you talk about sepsis, you're trying to see if there are bacteria in the blood. Does that make sense, everybody? Okay. Then that explains why you check for signs of it with a CBC. Actually try to detect it through a blood culture. Then you say, well, where does your blood go through? Your lungs. So you do a chest x-ray. Where does your blood go through? Your brain. So you do a lumbar puncture with culture, sensitivity, profile. Where does your blood go through? Your kidney. That's why we do a UA and a urine culture. Look up what a septic workup is now and understand it. And stop just memorizing. Okay? The key is when you pick up a pediatric book, it just says, here's a septic workup. That's what you're supposed to do. But you have no idea how they connect all these labs. And that's why you'll know it today. Tomorrow, you got to pull out that same book and look it up again. Here comes another patient a month later. You forgot how to do a septic workup. You got to pick out the same book again. Figure out what to write on the doctor's orders. If you knew what that word meant, you could figure out all the labs on your own. Okay? So that's what you got to rule out, sepsis. Now, after you rule out sepsis, if you got jaundice with mostly conjugated bilirubin, then that means there's an obstruction in the biliary tract. And I gave you that differential yesterday because we call that cholestatic jaundice. And Dan remembers in the newborn, cholestatic jaundice. They'll give you clues like high alkaline phosphatase because the biliary tract produces that. And Dan remembers the top three things I gave you, which were? Mustafa remembers what I said yesterday. Cholestatic jaundice in the newborn. Maybe Jennifer remembers what I said yesterday. Cholestatic jaundice in the newborn. All right. May hopefully remembers what I said yesterday. She said, no, I don't think so, Dr. Grant. All right. Joseph, do you remember what I said yesterday? Cholestatic jaundice in the newborn. Diana, Manny's all over it. Beanish, rescue me. Choledochocyst, number one. Here goes everybody writing it down again. Didn't work yesterday, but now today it works, huh? All right. It helps if you say it. You guys keep writing it, and you haven't said it yet in 24 hours. You're not going to remember tomorrow either when I ask you. So choledochocyst was number one. Biliary atresia was number two. Annular pancreas was number three. That means you got to rule one of those out whenever you see cholestatic jaundice. Remember I told you those are the top three before you start talking about Roters and Dubin-Johnson. Those are rare diseases. Even though they show up on the list. Don't go picking those. Okay? Any questions on jaundice? So we played that one all the way through. All right, let's go back in the uterus and come on back down again. Oh, wait a minute. Let me play this out some more. Sorry, I stopped too short prematurely. All right, so now you got physiologic jaundice. The spleen digests all these RBCs. The problem is, how do I turn the erythropoietin back on? Because after the baby's born, erythropoietin gets turned off. How do I turn it back on? You have to wait till your hemoglobin is low enough to cause hypoxia. Jenny, when does the hemoglobin reach low enough to cause hypoxia? Remember I said anemia and hypoxia are not equivalent until you hit a certain level. 6 or less. Remember, 6 or less. So when does that reach? At 2 months of age. That we call that a physiologic nadir. That means, so we went from physiologic polycythemia now to physiologic anemia. The bottom of that anemia is at 2 months of age. Now with a hemoglobin 6, bam! Hypoxia, bam! Erythropoietin, bam! RBCs start coming out of bone marrow. But now your bone marrow says, hey, we're more than 2 months of age now. We need not hemoglobin F. Nicole, we need hemoglobin. Not hemoglobin F, you need hemoglobin A, correct. So that means you got to switch all your hemoglobin to hemoglobin A. That means that's a lot of erythropoiesis. Everybody follow? So maximum erythropoiesis is between 4 and 6 months of age. What do you mean nausea? That means you're going to use up a whole lot of iron, aren't you? You understand? That's why we screen for iron deficiency at 6 months of age, folks. Because we know maximum erythropoiesis, 4 and 6 months, you're going to use up a lot of iron. Make sure that baby's getting plenty of iron by that time. So physiologic polycythemia leads to physiologic jaundice, which then leads to physiologic anemia, and then which turns on erythropoiesis again, and then we get RBCs back to normal. Any questions? That's why if you got a hemoglobinopathy, detect it at 6 months of age. Does that make sense to everybody? That's when you're going to see it. Like sickle cell, when do you screen for? 6 months of age. See, this way you're not just memorizing recommendations. It has to match what we actually see. Mark. Let me see. Well, there's some iron in breast milk, sure. But there's more iron in bottom milk. We'll talk about that at the end, though. Yeah. All right? All right. So one more physiology, and then we take a break. All right, back in the uterus. We're going back in the uterus. Come on back out. Well, on the way out, we said the baby's hypoxic. In utero, I took you guys through the oxygen, the PO2, through various levels. Starting out with where's the highest PO2 in the fetus, Eros? Which vessel? Umbilical what? Vein or artery? The other way. Umbilical vein is coming back from the placenta. Remember, the baby breathes through his placenta in utero. All right, so now we say the PO2 inside that baby is around 40 to 50 on the average. Now when he comes out, he breathes in his first breath, and guess what? His PO2 goes up to like 80 or 90. You just more than double your PO2. That's what shuts off his erythropoiesis. That's first breath. Shut off erythropoiesis. Okay? If your PO2 rises, prenema, what's going to happen to your pulmonary vessels? Constrict or dilate? That's correct. PO2 is going to rise when the baby's first breath is taken. What's going to happen to the pulmonary vessels? Constrict or dilate? They're going to dilate. Everybody follow along. All right. PO2 goes up. Pulmonary vessels dilate. What happens to pulmonary resistance, prenema? Goes down. What happens to pulmonary vascular pressure, prenema? Goes down. What happens to pulmonary blood flow, prenema? Goes up. What happens to pulmonary capillary wedge pressure, prenema? The flow is the wedge pressure. So wedge pressure has to go up. So what happens to S2 splitting? Widen or narrow? Widen. Prenema just told you the pulmonary manifestations right after you take your first breath. How many books did you have to read to figure that out? I can swear it's the same physio we talked about before. That's my point, folks. Learn your physio and biochem, then apply it to any situation you want to. So that means with the first breath, bam, pressure goes down, resistance goes down, flow goes up, S2 splitting goes up, wedge pressure goes up. Boom, we got pulmonary blood flow established. Now, pulmonary resistance is so low that systemic resistance seems much higher. Remember, in utero, it was the opposite. In utero, right side of pressure was high because the lung was not working in utero. Now, all of a sudden, the lung is doing the work when they're born. Systemic now has higher pressure. Everybody understand me so far? Okay, so when a baby is born, the right ventricle is usually thicker because that's the one that's been doing all the work in utero. Everybody follow me? Okay? So now I get all this oxygenated blood coming back from the pulmonary, and it dumps into the left atrium and into the left ventricle. You follow me, Kathia? Okay, so what happens to the end diastolic volume of the left ventricle? Is going to increase. So what is going to happen to your contractility? No, by Frank Starling. Increase EDP, increase contractility. So what's going to happen to your cardiac output? It has to rise. What happens to stroke volume? It's going to increase. So what happens to carotid stretch? It should increase. What happens to fire myocardium nerve 9? Increase. What happens to fire myocardium nerve 10? Increase. And therefore, what happens to heart rate? Decrease. Right after they're born. Whoa, look at this. I don't hear anything new. And we're talking about Pete. I hear the same physio. Okay, just to let you in on it. All right, so there it is. Everybody following so far? All right, so I got pulmonary circulation established. Now all of a sudden cardiac output is going up, and the baby's heart rate starts coming down. Remember, in utero, it's like 120, 160, and it's going to start dropping as soon as they're born. All right. Everybody understand that part so far? All right, now I got more blood flow on the left side with higher pressure on the left side. As soon as that blood came into the left atrium, because there's higher pressure on the left atrium, you close the foramen ovale. You push the secundum onto the primum. Foramen ovale is now closed. So I'm going to show you is the oxygenation that closes all those fetal circulation that we've talked about before. So as soon as the blood comes to the left atrium, boom, close off the foramen ovale. Well, we found out that as you get older, you can reopen the foramen ovale. All you do is raise your right-sided pressure, and the foramen ovale will open right back up. So who do we see that in? People with COPD, especially restricted lung diseases, right? High right-sided pressures. Foramen ovale open right back up. Remember, DVT that caused a stroke, how did they get it? Foramen ovale will reopen. Okay? All right, so now, foramen ovale is closed. So now the blood goes through into the left ventricle, gets pumped out into the aortic arch, and it goes around the aorta, and then sees, hey, there's a connection here called a PDA. But now there's higher pressure on the left side. That means aortic pressure is higher than pulmonary pressure. Blood now shunts left to right through that PDA. Because in utero, Linda knows it was right to left. Everybody with me? When oxygen goes across that PDA, PDA starts to close. The majority of PDAs are closed after 48 hours. So fetal circulation, all the shunts in utero are going to close because of oxygenation. Manny.
I never understood this. You said oxygen causes dilation, but why is it that when oxygen...
It dilates the pulmonary vessels only. Only. Yeah, that's it. No other vessel dilates with oxygen. The rest of them constrict to oxygen. Yes. Okay? All right. So we've got the foramen ovale closed, PDA closed. If you want to keep a PDA open now, what drug you want to give them?
You want to keep it open with
Okay. So PGE, what's the name of that PGE you want to use to keep the PDA open? E2, but there's a name for it. Lucas. Alprostadil is the one. And then if you want to close it, like Al said, give him indomethacin. All right, so now blood goes down the aorta and then goes through the two umbilical arteries. If ever you see only one umbilical artery, you must do an echo. Remember, heart and vessels develop at the same time. So if I see one abnormality, you got to check out for another abnormality. So if they ever describe a baby with one umbilical artery, rule out congenital heart disease. Okay? So the blood then, oxygenated blood, goes through the pulmonary arteries and closes umbilical arteries and closes them off. They become the medial umbilical folds. Ligaments, folds. Fold is the middle. Okay? The umbilical arteries will scar up and harden up and become the medial, that means off the midline, medial umbilical ligaments. And then the blood comes back through the umbilical vein, now oxygenated, scar him up. What is he going to become? The midline, median umbilical fold. So now I've closed off umbilical arteries and umbilical vein too. Okay? Now that blood goes through the inferior vena cava, or iliac veins, inferior vena cava, and then goes through the final shunt, which is the ductus venosum through the liver, and closes that one off. And that one then becomes your ligamentum teres. So oxygenation, Frank, closes off all the fetal circulation. Do you understand that? Because that's why we see any baby who's born who's hypoxic, RDS, congenital heart disease. Notice all of those shunts stay open. We call that persistent fetal circulation, or PFC for short. Anytime a baby remains severely hypoxic, those shunts will stay open. The problem, Ferdy, of all the shunts that I just spoke of, which one would bother that baby the most? Which one would be the most detrimental for his life? The PDA, he says. Why the PDA, Ferdy? Because it involves what? Well, all of them involve the aorta somehow. Why are you worried about the PDA more than any other one? Most of them are right to left shunts in utero too. Question is, why am I more worried about that one, Linda? Rebecca, why are you more worried about a PDA than the other shunts? Miguel? Why? Well, the pressure in her left atrium is not that much higher than her right atrium. That's why there's not much shunting through that one. Tina, which one would bother you the most? Tatiana, which one bothers you the most? Why the PDA, Tatiana? All right, the PDA bothers me the most, folks, because you are flooding that baby's lungs. You're creating a huge VQ mismatch. And you learn about VQ mismatches. That means severe hypoxia. That means you're about to vasoconstrict the pulmonary vessels right back down so that no blood can go through there. They're going to die. Because you're going to get irreversible pulmonary hypertension that baby cannot pump against. They die from cor pulmonale. No good. Guess why we try to close that one with endomethacin and let the other one slowly close by putting oxygen in their face? You got to ask yourself, why would we start doing studies and experiments? Why do we want to close this one? Because this is the one that's the most deadly for that baby. The other ones, just keep putting oxygen on them. And eventually, they'll all close. But we don't want to wait for the PDA to close because you might cause heart failure by that time. This is a newborn baby. All right, so persistent fetal circulation is anytime the baby's hypoxic or cyanotic, you're not going to close those.